and welcome to Mormon Sex Info. This is Natasha Helfer Parker, and today I have with me Kristin Marie Bennion. Kristin is an AASECT Certified Sex Therapist and is the owner and founder of Intimate Connections Counseling, located in Orem, Utah. She's been practicing as a licensed mental health and relationship therapist for over 6 years, and she specifically works in areas of women's sexuality, desire discrepancies in couples, intimacy enhancement, out-of-control sexual behavior, the intersection of faith and sexuality, improving body image, couples therapy, and eating disorder treatment. She's appeared on KSL television and local radio stations, has published articles for local news outlets, and given lots of community presentations on topics such as healthy sexual development for youth, sexuality, and the single life. And she's a graduate from BYU. About 90% of her clientele are LDS, and she really enjoys working with that population. And so I just want to say welcome to the show, Kristin.
Thank you. It's good to be here.
Very happy to have you. And today our main topic is going to be about genital pain. And this is something that comes up a lot in different forums where people ask questions, or even within our clientele, and something that seems to be really hard to know how to get good information about or even know how to talk about. So excited to have you talk about this issue.
Me too. It turns out it's a topic that I have really grown to enjoy working with these specific clients, and I'm really hopeful that we can get more helpful information out there.
Okay, great. Well, so in the classic DSM-5, which is the handy-dandy kind of Bible of all things that I guess can go wrong in our mental health and sexual health, is it's listed as genitopelvic pain or penetration disorder. So those are some big words, and so I just like to start off with maybe you helping us understand the definition and what we're kind of talking about.
Sure. So the DSM, like you said, it's kind of the dictionary for all of mental health diagnoses, or but the biggest umbrella I think that most providers use is dyspareunia, which is just an umbrella term for sexual pain or pelvic pain, genital pain. I think you'll hear all of those terms kind of used interchangeably. So for the official diagnosis for genitopelvic pain, penetration disorder, or dyspareunia, someone has to be experiencing discomfort or pain for at least 6 months. And a person experiences either persistent or recurrent difficulties toward vaginal intermission that is usually manifested in really intense fear and anxiety in anticipation of sexual intercourse. The second category is also they experience actual pain in the pelvic or vulvovaginal area. And then the third is marked tensing or tightening in the lower pelvic and inner abdominal muscles during attempted intermission. Like you were saying, that would be the vaginismus. So one of those three, someone would get an actual medical diagnosis of genital pelvic pain and penetration disorder.
Okay, so as you start talking about some of these words that tend to be kind of anatomical, and although maybe you and I are used to them, they can be maybe a little bit confusing. Why don't we start with just a bit of walking through anatomically what we're talking about? Like what's the pelvic floor? What's, we talk about vulva versus vaginal pain. So can you just walk through a little bit of the anatomy behind all of this?
Sure. The pelvic floor, again, I'm not medical and neither are you, so I hope the listeners kind of bear with me as I explain this from a mental health perspective. The pelvic floor is the muscles surrounding the vagina, anus, the bladder, all the area of the pelvis, and the muscles are involved in that system. The vulva is the outer area of the female genitalia, usually located between the mons, which is the pubic bone area, down through the anus. Right at the top of the the vulva is the clitoris, which we can go into at some point, or you probably will during one of your other podcasts. And when it comes to the vagina, which we'll be talking about quite a bit during this podcast, there's the entrance of the vagina, which can have a lot of localized pain in that area. Conditions such as provoked vestibulodynia, wow, I struggle with that one, is an example where there's pain at intromission in the vestibule, which is that entrance of the vagina. Let's see, there is, we'll be talking about the skin in the vaginal wall, and where there's atrophy, which is, and we'll go into that, but the skin can atrophy where it will become, the texture of the skin can start becoming quite compromised given whatever might be going on. We'll also be talking a little bit with conditions such as endometriosis. And we'll also be talking about some of the other organs, such as the uterus and the fallopian tubes. That's going to be brought up also in some of the conditions that can contribute to dyspareunia in a lot of women.
So it seems like there's a lot of different possibilities here. So you started off with muscles just surrounding kind of the different genital areas. And of course, we know if muscles are tense or contracting, that can be a factor. You're talking about possible pain just in the outer vulva area. So including even maybe the clitoris. And then you're starting to talk about pain more internally as you start penetrative process, either at the beginning of the vaginal cavity or even deeper within as you start looking at the vaginal walls. Is that a good overview?
Yeah, it is.
Okay. All right. So then let's talk a little bit about who does this affect? How many women? We're talking particularly about women. There are pain disorders that can affect men, but this podcast is really focused towards women. We'll do that podcast later. And how many women are affected by this, and maybe start talking about some of the issues as to why this is a problem that starts cropping up for a lot of people.
So as of right now, there was a study that was done in 2003. It's still a little bit old, but they were they estimated about 15 million women had experienced chronic vulvodynia, which is the biggest and most common sexual pain disorder at some point. And
it's a United States study?
Yeah.
Okay.
Yes. Yeah, in the United States. Yeah, and I mean, it's really hard to tell because there's like with most female sexual dysfunctions, there's a lot of underreporting. And so it's hard to get an accurate guess or accurate statistic, but it's quite a few. And I'm hopeful that there's a lot more research that'll come out more and more over time, because I don't know if you see this in your practice, but a lot of my female clients who are experiencing this feel so isolated and feel like they are the only ones that are going through this, or something's just wrong with them and they should just deal with it and get over it. And that is just not the case at all. They're in need of care and treatment, and there's help out there.
Yeah, and even kind of the sense that maybe they were taught to expect that sex might be painful, and so even thinking that it might be normal, like this is just something I have to put up with because sex is supposed to hurt.
Absolutely. I think that there's a lot of really well-intentioned friends or family members that will say, yeah, sex will hurt at first, but it'll get better. Or they'll just say certain things that really set up the woman to be kind of bracing herself. And as you know, there's a lot of psychological pieces into when someone is experiencing any sexual activity for the first time. And it can be really difficult for them to not know at what point should I go get help? At what point is this not, that terrible word of normal or common, is something wrong? And then so many of my clients don't know where to go if they even do know that they want to get some help.
Okay. All right. So yeah, where do you want to go next as far as describing what types of issues might be coming up that women are anxious about or thinking about or experiencing that might start heading down this direction of I might have an issue here that needs to be looked at a little further?
Sure. We can just kind of talk about some, just generally speaking, if there's nerve pain or muscle and tissue pain or skin, and then there is a category of other kind of some other things that can cause difficulty in sexual activity. If someone is having so one of the best things that, and we'll get into treatment a little bit later, but one of the most important things, hands down, is to find a really good team. And there can be quite a list of medical providers that might end up being involved, but an accurate diagnosis of what is the source of the pain is going to really shorten the duration of treatment and hopefully lead someone to experience some relief, or even full relief. It's going to be coming from having an accurate diagnosis from a really good team. And so, and you'll be able to see this as we go on in a lot of the potential sources being either nerve damage to the pudendal nerve, or like we were saying, muscles and tissue or skin. So like I was saying, if the pain is coming from nerve pain, it's likely resulting from damage to the pudendal nerve, which it's basically the nerve that connects our pelvic floor and genitalia to the brain. And so damage can happen from the pudendal nerve by relatively small things. Like some people can experience damage to this nerve and they won't even know it. It can happen from bike riding. It can happen from falling down on your bum. It can happen. It doesn't have to be what we would consider probably what comes to our mind when we think of trauma. And so this is a really good one, a really good example of why it's so important to get into a really good medical provider that is looking for this being a possibility of being the source of the pain.
You're talking about nerve and muscle and skin damage, and like you mentioned, neither you nor I are medical professionals,
right?
And yet we also treat these type, we're part of that team that you're talking about. So do you want to talk a little bit about who would be a good, how you form a good team? Who are the players in a team that might treat genital pain, and what does each player do in their roles?
Yeah, I'd love to. I've grown to be a bit biased whenever someone comes in I'm a sex therapist, so if someone's coming in for mental health treatment with the sexual dysfunction in the sexual realm, I've grown to be a little biased to say let's find a specialist, someone that fits for you with what might be going on. So there are gynecologists that could fit the source of whatever pain that client might be that source of pain that client might be experiencing. For example, endometriosis, it would be a really good idea to find someone who specializes in endometriosis, a medical doctor, to give that medical diagnosis. Does that make sense?
Yeah, for sure.
And then if someone is having, let's say, pain in the vulvar area, which is that outer genital area of the female anatomy, if there's discomfort on the skin, then they might it might be in their best interest to find a dermatologist that specializes in the vulvar area, which there are some, but it might take some research and calling, to get a good recommendation. So with any of my clients that are experiencing that, vaginismus, or where the pelvic floor tightens up upon any intermission or attempts of intercourse, a pelvic floor physical therapist is just amazing to incorporate into the team. Through going to a pelvic floor physical therapist, this not only can be very empowering, because a very good pelvic floor physical therapist will walk the woman kind of through her anatomy. One of my favorite pelvic floor physical therapists here in Utah will actually have the patient hold a mirror so that they can kind of understand their anatomy a lot better, and they can be a lot more empowered to know exactly where their pain is, what type of pain it is, and then also so that they can learn to treat themselves, so they can be empowered through the process. I've just really grown to love pelvic floor physical therapists being incorporated into the team. And there's also pain specialists for certain conditions, neurologists, and urologists can also sometimes be involved depending on whatever condition might be going on.
Yeah, and I think I just want to normalize that it can be difficult to find these types of specialists depending on what area of the country you live in. If you live in a rural area, this might seem almost impossible, or you'd have to travel to a bigger city to kind of create this type of team. And even people who have been to what they would think are, a good gynecologist or a good urologist, that doesn't necessarily mean that they specialize in these types of sexual disorders. And so it can feel really confusing to figure this piece of it out.
Absolutely. And I think what makes it's just frustrating to recognize how much, how unfair it really is to a lot of these women, because it's already likely a topic that has them feeling like they're already going out of their comfort zone to report this anyway for a lot of these women. And so to feel like you're getting the runaround or not even know that your intuition might be correct, that you are, having an impression that is different than what diagnosis or feedback you're getting from the doctor. I mean, this is any sexual pain, especially female sexual pain. There are just report after report of going through multiple doctors before they get someone who they actually feel is listening to them and is giving them an accurate treatment and diagnosis and all of those things. And so I think that's where a lot of my bias has come from, where let's find a specialist, someone who let's try to just cut out a lot of that middle ground. There are fantastic gynecologists out there that would probably be able to do a great job, but some of them might miss it, so finding a specialist would be probably in the better interest if you live in an area that they can.
Yeah, and I think, too, another thing that I hear a lot, because, you and I work more on the psychological aspect of this, and this is an interesting interplay between psychology and physiology, and they definitely affect each other, but oftentimes I have clients come in who feel like their doctor has basically either directly or indirectly said, this is just all in your head, and you just need to learn how to relax. And although relaxation may play a significant role in learning how to have, pleasure-centered sex, it's often not the only thing happening.
Absolutely. And I don't know if there's worse things that some of our clients can hear when they're already coming from such a place of shame, where they're being told that they're just making this up or anything. And I know that's not really exactly what they're saying, but that is sure what it feels like, or that's what they're hearing. And so that just really isn't very useful, even if the doctor feels that way. There are better ways to say, let's incorporate, make sure you're seeing a sex therapist that can help with some of that cognitive behavioral pieces that we can get into, Natasha, but because those are helpful, and that is very, very useful when you talk about a team. I am certainly saying a sex therapist or sex educator can be very helpful along with the medical piece. But there are way too many reports of clients feeling dismissed, or patients feeling dismissed by their providers, just saying it's all in your head. Just, it got better for other people, so why doesn't it get better for you? It's just very dismissive.
Right. Okay. So going back to some of the ways that you're talking about these issues, you started with nerve function. And I think did a really good job of expressing that can be an issue. What else would fall under your different ways of categorizing?
Okay. Well, these are really brief, but I'll just touch on a few of them. So with muscles and tissue, we're all really affected by our hormones. I know we all are. And it can contribute to decreased estrogen and testosterone, which leads to the thinning of the vaginal and vulvar tissue. And I know you went over a lot of this with Alicia in one of your other podcasts in talking about lubrication and how that can be very helpful. But I think this plays into that a lot. it contributes to skin irritation from dryness, sometimes tearing, which, it can be incredibly painful, not only painful, but also kind of dangerous, and a lot of discomfort. A common area impacted by this hormonal change is the entrance of the vagina, like we were saying. And increasing research is also saying, which this is kind of frustrating that it's just now coming out to me, but increasing research is coming out that the impact of oral contraceptives can have quite an impact on hormonal levels, contributing to that pain upon intermission or that entrance of the vagina. And so I am really hopeful that they come out quickly with more, because there are a lot of people that are just handed, birth control by their doctor, and by no means are having any sort of informed consent, in my opinion, on the possible effects that even just a daily oral contraceptive can have on their sex life.
Yeah, and so looking at a stereotypical LDS example of this might be that, here's a young woman who's about to get married, and she really hasn't had much, if any, sexual experience prior to marriage. And of course, as part of getting married, she goes in and has her appointment and gets on an oral contraceptive. And then, has her first sexual experiences, not even knowing what sex might be like without an oral contraceptive.
Right. Absolutely. And so again, we're kind of, some of these women are being kind of set up and not informed on what their body needs, what to look for in case something is, I don't want to say necessarily wrong, but they could use some help or some attention to certain things, or things could just be better. But like with the conversation about lubrication and what types are better for the vaginal area, and what types should never be anywhere near the vagina, that are sold in the, Walgreens. And so.
Right. Yeah. And that we're not necessarily saying don't go on oral contraceptives. That can be a really important piece of family planning, but just
Absolutely.
being educated and aware and what different types might work best for your body, or even other types of contraceptive.
Yep.
Okay. So you mentioned that tearing can even be dangerous. What do you mean by that?
I think the word is micro tears. I've heard from others that know so much more about this than I do. But without adequate lubrication or continuing to engage in sexual activity when the skin has just basically been kind of rubbed raw, it can create what they call micro tears. And again, I think there's a lot more that can be said about it, but it can lead to more infection. It can lead to a lot of other issues that can create even more pain or discomfort down the road.
Okay. All right. So we've got possible nerve damage. We've got muscular and skin damage, maybe affected by hormonal levels. So it's a good idea to have your hormone levels checked.
You bet.
As part of your medical treatment. Anything else?
I think an important one, which is talked about a little more often, is what we've said, the vaginismus. And I mean, I know the DSM has now changed the name, but I think it's still pretty widely used, which is when the muscles around the vagina, the anus, and the bladder, they can spasm, basically preventing or making it incredibly difficult and painful to have intercourse. And so the muscles spasm and cause pain it's right at the entrance of the vagina. And this can be incredibly distressing for any female experiencing this, especially if they're wanting to engage in sexual activity, and their body seems to be saying, no, I don't want to do this. And so it can be very, very difficult on a marriage or in a relationship.
Right. Almost a betrayal of your own body in many ways.
You bet.
How many speak to me about it.
Mm-hmm.
Okay.
Mm-hmm.
Okay, well, where do you want to head next then? As far as we've talked about some of the things that come up for people, different types of pain, different areas of genital pain, different things that might be contributing to that.
Can I add just a few other random ones just on the...
Yeah, please.
Really quick. Some other things that are just kind of in a catch-all category, I think, but it's, I mean, in reality, a pretty long list, but I'm just going to keep this really short, are, some conditions such as endometriosis, where tissue within the uterus can grow outside of the uterus and cause all sorts of discomfort and pain. Other conditions such as gastrointestinal conditions, like IBS can inadvertently cause sexual pain. And then also
can you explain what that stands for?
IBS is irritable bowel syndrome. And so these poor women who are already experiencing so much discomfort in the gastrointestinal system, I think the sexual pain, I could be wrong on this, but I can't look it up right now, but I'm pretty sure the sexual pain is secondary to the gastrointestinal concerns. IBS, and I know ulcerative colitis can also cause secondary sexual pain. And so I think what's difficult is that a lot of women who are experiencing these things, they're already so focused on caring for the symptoms that the symptoms of sexual pain probably don't get really looked at very much. Not only does it potentially cause genital pain, but it also will understandably decrease sexual desire. So there's a large impact on one's own sexual experience if there are some even gastrointestinal conditions that might be going on.
Okay, yeah, that makes sense.
And then lastly, some infections such as yeast infections and BV. A lot of people they've reported that after yeast infections, they can be put on antibiotics. And antibiotics are great, but not only do they wipe out bad bacteria, they also wipe out good bacteria. And that can start the ball rolling for some potential genital pain as well. Some STIs can cause genital pain. I will say that a lot of people believe that any sort of sexual pain or dyspareunia is coming from an infection, and yes, it can happen, and it does, but it's usually not in the majority. It's usually some of these others that we've mentioned.
Okay.
But it's still really good to go to a qualified medical provider to get an accurate diagnosis.
Right. Okay. So are we ready to move into maybe some of the psychological pieces of this? Is that
sure?
Okay. What are some of the inner messages, or how do people tend to think about these things before they've received treatment? So what are some of the misconceptions or things that a woman might be saying to herself as she's dealing with some of these issues, or even spousal interactions?
Absolutely. And I don't know if you've seen this a lot in your practice, but I sure see it quite a bit in mine, especially with a few of my or a lot of my LDS clients that might be experiencing sexual discomfort, like physical discomfort, is they feel so alone. They're already coming from a place of, is this normal? We tend to be a wee bit perfectionistic in this culture, and so they're already coming from a lot of pressures to be a great wife and to please the husband, and there's a lot of duty stuff in there that can really contribute to increased amounts of shame. And so I'm listing all of these, and as I'm speaking about them, I'm recognizing they are just major barriers to getting care and getting treatment. So I think one of the biggest barriers I see is just second guessing oneself and not really being, I think you said this in one of your other podcasts, just not really leaning into becoming one's own authority on her body and saying, this does not feel right. This does not feel like I want to keep doing it. This is getting in the way of my own relationship with myself, my relationship with my spouse. I'm going to start researching this from qualified people because this doesn't feel like it's adding to my life. It's taking away quality. Does that make sense?
Yeah, absolutely. Especially because I think LDS women, as young women and single women, we're not really taught to embrace our sexual selves, right? We're taught to kind of protect our sexuality until we are married. And
Yep.
and so then we don't have a lot of experience or know how to even think of ourselves as sexual beings. And so when we come across a problem like pain, I think there's just a variety of messages that can go through your head. Maybe I'm not really that sexual. Maybe I'm not meant to like sex. Maybe I am kind of a religious prude. Which I think most women don't want to see themselves that way, but it kind of fits with some of the narrative that's been given to them to begin with. And then to claim, to say, no, I want to be sexual. Hey, I want to be super passionate and love sex. It's not like we've really given women in the LDS culture that type of narrative. I think that women oftentimes have taken a more passive role. And I might enjoy sex and it might be really nice. And I hope it will be, but not this, I'm going to go get it. I'm going to go get great sex.
Right. The narrative to claim one's sexual self, I think, is definitely missing for women in the culture at large right now. I think that's a massive barrier because I think, anecdotally with my clients, I've definitely heard things like, it's just not for me, or maybe I'm just not that sexual. But when I get talking to them and asking questions about what their, sexual template might be like, what their preferences are, they've never asked themselves that. So it kind of, it's implied there, and we start talking about it, it definitely comes out that to claim one's own sexual self and to really feel like you're thriving in your own sexual domain with your spouse and within, your own self, it just doesn't even cross their mind. So that can really be a way of keeping sexual pain around, because they're not fighting, it's not kind of instilled within the narrative to fight for your own sexual wellness and defend it. I think fight's maybe strong, but
no, I love the word fight, or fight for your sexual health and for your right to experience sexual pleasure.
Absolutely.
Those are things that we haven't necessarily talked much about, or
at all
given people those even kinds of ideas. Like, I have a right to experience this, and just like we have a right to walk without pain. If my knee is hurting me as I'm walking, I kind of go get that checked out, right? Or I've been dealing with plantar fasciitis, so I'm constantly talking. I feel like I have a right to walk without pain. It may or may not happen.
Right, but you have.
But there's nothing shameful about going to go talk to my foot doctor and say, "Hey, what in the heck is wrong with my flipping foot?"
I don't like that my foot hurts.
Right.
And so help me. Yes.
Right. Well, good. Yes, I think that's an important piece. And so if people get nothing else, is this idea of this is an area of your body that can have issues, just like any area of your body can. And if you're experiencing pain, it's not what you're supposed to be experiencing. And there are specialists and reasons why some of these things might be happening. And I think it's good also for the husbands to hear those messages. I think LDS husbands tend to have a lot of confusion, and it's very easy to get into that either it's my fault or it's your fault type of narrative, right? So I must be doing something wrong. I'm not a good lover. I don't know how to touch her. I don't know how to give her pleasure. Right. Or, boy, there's something wrong with you, the way your parents taught you about sex, or you don't have good sexual, energy, or, whatever it is we either blame each other or ourselves. And none of that is usually very accurate, for one, and second of all, definitely not very helpful.
Well, and I think on top of that, what I see in my practice, which my heart just goes out to them fully, is I think there's a belief still that, if you're waiting until marriage, or, you're saving, intercourse or whatnot until you get with your spouse, and then your spouse has sexual pain, there's I think some disappointment that things aren't the way that I was told that they would be. And so I mean, my heart fully goes out to the woman experiencing that, but I can also be very compassionate to her spouse who wants to be with her in the way that he's, wanting to fully express his own love for her and experience his own sexual, experience in the way that he wants to fully. And that really impacts the spouse heavily as well. It takes a lot of patience and a lot of education for them as well, because I think that can be very, especially if they're not talking about it, if it's just, ouch, it hurts, stop, and then they're not, discussing it, which is not uncommon, he really can start to believe that it is something he's doing, and have all sorts of shame for himself.
Yeah, and even, as you're talking this relationship with deity, it's like, goodness grief, like we waited all this time, for the couples who wait.
Yep.
We've waited all this time to enjoy this part of our life, and I've been, like this worthy LDS person, and I couldn't wait to explore and have fun in this area, and now we can't even enjoy our reward in a sense, right? Or just that expectation that I think happens with a lot of gospel principles is if I do A and B and C correctly, then I'm going to get, D and E as the reward. And life just doesn't really always work out that way. Or even the other side of things, like I'll have people who maybe did not wait until they were married, and so now they see this as some type of punishment, or like I'm being punished because I wasn't worthy, or didn't take care of my sexual purity, or it's just amazing how self deprecating we can be.
Absolutely. I don't know if I've had one client that didn't at least bring that up once, that it was on their mind. Like, did I do this? Did I bring this on? Was this because I did that one thing 10 years ago and didn't fully tell all the details, and to my bishop or whatnot? And I mean, just my heart just hurts for them. With that is just such an immense amount of shame and pain that they are carrying today. When, and it's great to be able to talk to them that there is nothing they did to bring this on, and there's help, and let's get that ball rolling.
Yeah. Okay, good. Well, so should we move into, then we maybe can have some basic understanding. We understand some of the stigmas or thoughts that we have about it to begin with, but now what do we do about it? Yeah, absolutely. So I think this falls also under the category of treatment. So if people are listening to this that might be going on for them or their spouse or someone that they know, get researching your team, like we were saying, but also it can be really helpful to start tracking your pain. So in the world of sexual pain, most will somehow at some point run across pain diaries, and so tracking your symptoms in a diary, what they are, when do they occur, what you were doing when they occurred, how long it lasts, and to get really as specific about the pain as possible. You can just go to Google and type in there, types of pain or words to describe pain. I think that's a good one. And to get as specific as possible in preparation for when you go to your medical provider, because that will just be incredibly helpful to have some information there for them. You just hand them your little list, and it can help them in their diagnosis of what might be going on for you. Right. Yeah. And even where exactly you're feeling the pain, right? Because if you go in and just say, well, it's just kind of in my vagina, but we use the term vagina to mean a lot of things. So that's why I wanted you to talk about the anatomy, because you want to say, no, it's in this outer labial part of my vulva, right? Or it's my clitoris feels raw and sore, or it's right at the beginning of penetration, or it's deeper, when it feels like he's deep within me, or those kinds of terms. Yeah.
Absolutely. And I mean, I don't know if you still run across this, but I still get a lot of, it just hurts down there. So it's just really hard to even say sometimes vagina. And so I think getting the ball rolling and all of this to me can be so empowering, where is it hurting? What part of my anatomy is that? I mean, I just think there's so much that can happen through this, where women can feel like they're reclaiming a part of their body that wasn't fully, within the narrative, it wasn't taught to them that it is theirs, and that it needs care. It needs to be treated as if it is incredibly important to them, for them. And so there can be a lot of really great things that can come out of going through something like this.
Yeah, great. And I think right in there, you're looking at a cognitive behavioral technique that we call reframing, so on the one hand, you can be thinking about something like, this is an awful thing that's happening to me and I'm so upset and depressed about it. And you can train yourself to rethink and go, okay, this is an opportunity for me to get to know myself better, to figure a lot of different things about myself out. And even though it's hard and I wish it wasn't the case, there's still some positives that can come from this.
Yep, absolutely. And another thing that I like to tell people or suggest when they go in for their medical exam is to ask to have a mirror there. And it's definitely uncomfortable for most people. And when I bring that up for clients, they'll usually look at me like I'm absolutely crazy. But that can really get the ball rolling for some empowerment in saying, hey, this is my body. I want to know what in the world is going on. And so help me understand. And most of the time, doctors are just phenomenal with it. The pelvic floor physical therapists, usually they'll do it anyway without even being asked. But if you feel like this has been a mystery to you, and you've said, I don't know what is going on, this is your chance to really start figuring out what's going on. And so I really want clients to feel empowered within the whole entire process.
Yeah, and it's something that I think the mirror exercise is one that we give often just to even people who are not necessarily experiencing genital pain. And it is that process of just getting to know your own body. There's so many parts of our body that we just get to see on a regular basis, and we know what we look like. We can tell if there's a rash or an infection or, something that happens on our skin. But most women have never really thought to take the time to really look at themselves in these genital regions and what does my labia look like? What does my clitoris look like? What does my vaginal opening look like?
Yep.
What's it like for me to look at myself, right? So usually at first there's some discomfort with that, or because it's new and strange maybe feeling to do that. But
Sure.
but you can really start developing a different relationship with your genitalia than you've had before. So even if you're not having genital pain, I guess my point is this can be a very useful exercise.
Absolutely. And then lastly, I think you've brought up a couple times CBT, cognitive behavioral therapy, is still probably the most common treatment modality for sex therapists, sex educators, and with the twist of mindfulness in there. There's a lot of addressing unhelpful thinking patterns, black and white thinking, catastrophizing, the whole list of cognitive distortions are usually going on for those that are experiencing any sort of sexual pain or dyspareunia. And so that can be really empowering to give them actual homework for when they're in their mind, what they can do at the doctor's office. They can practice these skills. They can practice these skills within CBT and mindfulness in the sexual realm or during a sexual encounter or outside. So there can be a lot of work they can do if they're not ready to engage in an actual sexual experience quite yet. And so that's where mental health and sex therapists can be really helpful to help with all of what do I do with all of these thoughts?
Yeah. Well, so can we talk about some specific either exercises or ideas that you have that are pretty common when somebody needs help from a cognitive behavioral standpoint, as far as maybe even something as simple as redefining what successful sex can look like? I think one of the things I talk about pretty immediately. I don't know if you'd agree, but if sex hurts, stop doing whatever it is that hurts, right? And but if that means it's penetration and you're trying to get pregnant, or it's penetration and that's the one way you thought you'd want to have sex, or the male is feeling like, well, I was really looking forward to penetration, penetrative sex. So these are some of the things I think that can be worked through. And again, it's not that we're never going to have penetrative sex again, but maybe let's just put that on hold for a minute until we can figure some of this stuff out.
Absolutely. Well, yeah, and I think that's an excellent intervention and also skill for them to be aware of, what are my core beliefs, or what are my just even distorted beliefs going on when it comes to sex. I think that whether they're having sexual pain or not, that we all are kind of buying into ideas about sexuality from day one in our culture. And so getting really familiar with what beliefs might be going on, like we said kind of in the beginning of this, a big one is sex hurts, but when you start, but it'll get better. Like even just that idea can really set someone up for some unnecessary, at least a lot of, for going through it alone a lot longer than they would really need to. But I definitely help them identify those thinking errors. I teach thought logs, so identifying the thought, rating the intensity of the thought, and then coming up with alternative thoughts that are also true. Because we tend to get really fixed and very narrow when we're afraid. So this is going to hurt. That's a good example. So the sentence, this is going to hurt. And then they can identify how intense they're feeling that thought or experiencing it. And then to come up with an alternative thought, such as it's starting to get better, or it didn't hurt last time, or this is a new lubrication. We're going to see how this goes and we can stop if we need to. I mean, just more balanced, more gentle thoughts. We're wanting to welcome them into the cognitive experience as well, because it heavily impacts the experience overall.
Yeah, would you feel comfortable maybe sharing, walking us through what that might actually look like in your office with somebody? So they come in with this, whether you call it catastrophizing or something, give an example of that, and then how they would rework it? Sure.
So it's basic thought log stuff, but I'll definitely go through and make it specific for, I'll have them go through, just like you're saying, a powerful thought that they experience. I call them frequent flyers. So what are your frequent flyers? What are the ones that come up for you? So a big one might be, oh, my husband's going to want to have sex with me tonight and I don't want to, or something like that. Or, where just it just locks them up. They get very afraid. The thought impacts their feelings and their behaviors heavily. And so I'll have them come up with their list of their frequent flyers. So going to maybe a sexual encounter, a frequent flyer of a really hot thought or a really impactful thought would be, like I said, this is going to hurt really bad. That thought right there, if let's say someone has gone through treatment and they're starting to experience less and less pain, then they're kind of in the part of treatment where they're rating their level of pain. So it's just inevitable that they're going to be kind of daring to have some sexual experience and to see if it's getting better. So if they have that thought, this is going to hurt really bad, that's a pretty impactful thought to have that can make it very hard to relax. It can make it very hard to experience pleasure. It can make it very hard to stay present with one's spouse or in the sexual experience. All of these things are so helpful in order to have a pleasurable, fulfilling sexual encounter. And so if we're having thoughts like this is going to hurt really bad, then that's going to be not helpful. So it's good within the cognitive behavioral therapy realm, that skill set, to be able to identify the unhelpful thought and rate its intensity on a scale. I usually use scale of 1 to 10. So if somebody is experiencing this is going to hurt really bad at an intensity of 9, that's going to be, they are really, really scared. That's a very, very loud thought in just how I put it. And so through their work, they're going to know that there's a few other alternative thoughts that they could find to see if they can help that really unhelpful thought get a little bit more loose and not as loud, and to open up to maybe there are some other possibilities for what might be going on here. And so an alternative thought to this is going to hurt really bad might be, it didn't hurt much at all the last time, if that's true for them. Or last time we used this lubrication, it really actually felt kind of good. Or, this right now is feeling not bad at all. So just kind of creating some other truths to also hold. And then, if they're really being cognitive behavioral therapy centric, then they'll probably rate their original thought right after to see if it's still strong. But, so we like to help them feel more empowered even within the way they think, so that their thoughts aren't making it worse or harder.
Yeah, and I think that there's great potential. Maybe we can take a tangent here on how to include the spouse, the husband, the partner, because one of the thoughts that you might have is, if it really hurts really bad, as far as I'm afraid, as much as I'm afraid it will, one of the thoughts maybe I can have is, it's okay for me to tell my partner that we need to pause or do something different, so that it doesn't feel like, you mentioned all or nothing, like I have to have sex or I'm going to stop having sex. So maybe we can have sex in a different way, or maybe I can take a break and we can just cuddle for 5 or 10 minutes until I, calm down, or some of those things. So what are your thoughts about how do we incorporate the partner into this type of team approach as well?
Oh, I think that if there's a chance that the partner can be involved, which they're 9 times out of 10 probably should be there, then go for it. Because there's so much that they can do in the moment to help remind, when we're scared, when we're afraid, when we've got our thoughts going a million miles an hour, it can be very grounding to have one's spouse remind them of a few of the skills that you've gone over, either with the pelvic floor physical therapist. I know a lot of them will want to incorporate the spouse in being there as well, or, in sex therapy, for them to know there are a few things that they can remind her. It can be so helpful to have someone there to help ground you, bring you back to the now. And also to validate, because I like what you just said, or I just think it's very common for women to feel like they can't say stop because they're going to disappoint their husband, or, they just are just carrying on way too much pressure to advocate for their own sexual experience. And so they'll just keep going, and it just is too painful, and it's really going to actually hurt the progress if they don't feel empowered enough to say, okay, I've reached a bit over a sexual pain rating that my pelvic floor physical therapist told me to never go over, say 1 to 10. I usually use 1 to 10. So if the pelvic floor physical therapist said don't go over a 3, and I just hit a 3, well, I'm going to need to tell my spouse that. And if she's really stressed about it and he knows that she's supposed to say that, he can maybe gently remind her, where's your pain scale? And then, she can, oh yeah, I'm supposed to tell him, or just, it's a team. It's very intimate. It can be very connecting for a spouse to be there for her in that way.
Well, and I love that you said that, because again, I can see people thinking, well, that sounds romantic. That's the type of sex I want to have, right? Is to check in on a pain threshold measurement scale.
Sure.
But what you just said, there's so many things, whether it's putting on a condom or checking in on a pain measurement scale or having to change positions, or whatever it is that can be incorporated into a sexy, fun, playful, caring, intimate, whatever all those words you want to use can be, that it does not have to break the mood, or be an an interrupter of the intimacy that's happening. It's just part of our intimacy. This is part of the conversation we're going to have to make our intimacy even that much safer, that much funner, that much more communicative.
Right. Absolutely. It can be very good. I think it's excellent if a spouse can be there.
Yeah, great. Plus, I think, back to our point, it helps a lot of spouses feel like, oh, I can play a role in here. Again, most spouses are wanting to be a part of the solution. You know, they're not wanting to be part of the problem. And so it can help a spouse feel empowered. Like, oh, there's something I can do, or there are strategies I can think about having so that I'm part of the team as well.
Absolutely.
All right. Do you want to talk about maybe moving away from cognitive behavioral things or strategies? There are some things that can also be helpful, such as we could talk about dilators, we could talk about special creams or ointments, we could talk about just the different maybe things that are out there that somebody who's dealing with some of these issues might come across as part of what providers might recommend.
Yeah, let's hit a few of those. I think just generally speaking, it's just good to know that things like dilators, Kegel balls, and certain I guess more medical instruments can be utilized to help with any number of these. But I think what's important is to know that every single separate diagnosis has a different, likely a different treatment. So for one sexual pain condition, they might recommend dilators, and then for another, a dilator recommendation would be very harmful. And so that's why, again, we go back to always making sure you have an accurate diagnosis and not just look it up on Google or just take, a friend's advice like, oh, my doctor recommended a dilator before I got married, so here, just use this, I'm sure it'll help. No. That would not be what we'd recommend at all. Make sure make sure you have an accurate diagnosis so that you can then get the treatment that you can follow through on your own. I think that would be the best recommendation by far. And then when it comes to the ointments or salves, or the list goes on. I don't know all of the names of them because they're changing so much. But each I guess treatment medication, whether it's in a form of a cream, it depends on where it needs to be applied to. For example, with the entrance of the vagina, that's why it's so helpful to know exactly where the pain is. You remember with that mirror exercise with the pelvic floor physical therapist or gynecologist, where they'll tell you exactly where to apply the cream, and it's just so empowering. And not only is it empowering, but it's also treating it. It's not just kind of shooting in the dark. And so I think that's kind of what I would generally say about that.
Yeah, no, I love that you said this idea that, just because there's a treatment out there that's, generally going to help genital pain, that it's going to help every single situation. I remember at one of the last conferences I was at, it was surprising to hear, like, even something as simple as Kegel exercises, right? We're all told to do our Kegels, which is this exercise where you're supposed to kind of contract your muscles, just like if you were urinating and all of a sudden you wanted to stop the flow of urine, then you contract this muscle, and that's your Kegel muscle. Right. And that for a majority of women and even men, this can be a very helpful exercise because it keeps that area, those muscles strong, especially as we age, and we don't want to, have bladder incontinence and all those kinds of issues. But for some women who have, kind of this muscular tension already, if they're doing Kegel exercises, they're actually exacerbating the problem of, instead of learning how to relax their muscles, they're actually making their muscles even tighter and can be quite harmful for penetrative sex. So that was a very interesting insight just on one particular thing. So
absolutely,
I agree with that. Can you spend a little bit of time again? I feel like sometimes we know what we're talking about, but not everybody else does. So what are some of what is a dilator? What are some, I think you mentioned was it the balls?
Oh, Kegel balls. I think
so. Can you
probably
just,
the way of saying it.
yeah, describe a little bit what these products are?
Sure. I will try to describe. So the dilators are they're various tools that are in the shape of kind of like a cylinder that are at various sizes. There's usually, I think, 4 or 5 sizes, where I think the most common, I think, thought about a dilator or dilators is when someone has not engaged in any sexual activity before getting married, and a gynecologist will generally recommend, hey, you can just try these for a few months up until you get married, and that will make intercourse for the first time be easier. And I think, like you said, that might be helpful for a lot of people. I, of course, am also biased that I think they need a lot more education as to even how to use them. Some don't get that; they just get the recommendation to use the dilators. But so that I think that's the most common recommendation for them. And so that would be kind of a dilator set. There's usually 4 or 5 of them. The Kegel balls are just these little, how big? I don't know, quarter diameter size, maybe even a little more. Usually used to strengthen the pelvic floor, where they're inserted into the vagina, and women can utilize them in strengthening the pelvic floor by flexing. There are so many other uses for these. I'm totally probably thrashing it, but again, this is for more of a where they're using it to tighten and to strengthen, I think is the better word, the pelvic floor, vaginal area. But if somebody, like you said, is experiencing one of the like vaginismus, where there's a tightening and a spasming of that area, it can be very harmful and damaging, not helpful at all. Was there another one that you wanted me to say, Natasha?
I think those were the 2 you mentioned. I don't know if there's any other ones you would think of. Those are the main 2 I'm aware of as well that are oftentimes given out. And I've heard too the dilators, not just for people who are preparing to have sex, but again, may have some penetrative sex pain, or just feel like that discomfort, right? Or so they kind of, the idea is that you kind of find yourself in a relaxed space and you insert this initial dilator, the one that's thinnest, and it's almost like inserting a tampon in a sense, and you just kind of sit around and relax, and it's not a sexual type of exercise. You're not supposed to be necessarily aroused. It's just allowing your vaginal muscle to be used to something kind of inserted, and then you increase the size as you increase your comfort with some of those. I know some women, they're unsuccessful even in getting a very thin dilator, or even in wearing tampons, because of some of these genital pain issues. So again, it needs to be very individualized.
Absolutely. And I think the dilator use with genital pain, I mean, after there's the accurate diagnosis, and I mean, I think ideally if the spouse has been able to attend the pelvic floor physical therapist or gynecological exam, they've also learned how to, the exercises for using the dilators. And then if they can also attend the sex therapy, where they also are the partner in learning, these relaxation techniques, cognitive behavioral reframes, that is just a true partner, I believe. So it's just really an opportunity to be there for their spouse. And yeah, it isn't very sexual, but I think there are quite a few spouses that are involved in the dilator exercises as well, which I think can be a good preparation if it's right for them. It's different for every couple, but it can be a good preparation for eventually getting to where the pain is minimal or non-existent enough to begin with intercourse again.
But let's briefly discuss how pregnancy fits into this issue of genital pain.
Okay, this is a big one, but I'll go way quick on this one. I think one of the things that comes up quite a bit for me, I don't know if it's the same for you, Natasha, in my practice, is nervousness for after birth, or during birth, obviously, but then after birth and engaging in sexual activity after a vaginal birth. And so I've gone over quite a few times how just some preparation things that people can go through before giving birth. My go-to, hands down, all the time is empowerment. So there's no stupid question. There's no weird question. In fact, I have never heard a stupid question. I think every question that I hear is pretty darn understandable that someone has, especially with something like pregnancy. Most of the time it's a first-time mom, or, maybe their first birth was a C-section. They're going to try to have a vaginal delivery after, I don't know. But I think everyone deserves the empowerment to get their questions answered as much as they can. And so there's some preparation that they can go through before having a baby to prevent tearing or having an episiotomy, or and then care for afterwards. I unfortunately continue to have clients telling me that after care from the birth, that there wasn't much education or information on how to care for their vaginal area, or what might be some pink flags, red flags for when to call. There's just a lot of mystery post-birth. And so they probably get sick of me saying, but, well, let's get your questions answered. Call them now. There's no stupid question. Be the squeaky wheel. I don't care. You need to have that empowerment and those answers. This is your body. This is your family. So yeah. Oh, and then really quick. So one of the things I definitely go over is that the 6-week mark, which is this, I guess, historical myth that the 6-week mark is automatically just a green light to head right back into intercourse. And I will challenge that pretty darn quick, that I think it can be another opportunity to have, just go slow, to be very mindful, and to have kind of a plan with your partner. I mean, there are quite a few that start with just genital play. They definitely don't go into intercourse right away. Gauge any sort of discomfort. Make sure to have plenty of lube there, because the decrease in estrogen will likely, the impact on estrogen can very much so impact their body's natural lubrication, which causes discomfort for most women, if not all. So yeah, just empowering them to get questions answered, feel prepared as prepared as they can. Anything else that you can think of, Natasha?
Well, not that anybody wants a lot of my own personal information, but one of the things that shocked me, I was shocked after having a C-section, was the amount of vaginal pain I had during sexual intercourse. Nobody had told me that was a possibility. I just assumed that because I hadn't had vaginal trauma in particular, that I'd be fine. Not understanding kind of some of this, what you're talking about, that the estrogen and my hormonal levels were definitely having an effect on the quality of my vaginal wall, or, so that whole area was still very much affected, even though I didn't necessarily have that. And I really like your mentioning, what was it? Is it 6 weeks usually, right, that they say?
Yeah.
And that use that as a guideline, because, some women I know I've heard are kind of ready to experience some sexuality before then. If you've had an episiotomy or had some more traumatic birth, it may be quite a while later than that you feel comfortable. And then again, the importance of negotiating your husband's sexuality during that time. And, what do you both agree can happen for him? So is it okay if he masturbates or not? Is it okay if he can rub up against you or do other things with you that don't necessarily have anything to do with your genital area, right? And so, because I think sometimes there's this pressure to manage your spouse's needs, even though you're not in a place where you can really offer that.
Yep.
And so I think those are all just really important conversations to have, instead of putting yourselves in these meaning ruts, or this is how it should go, or there's something again wrong with one of us or both of us if these expectations aren't met or these timelines aren't met.
Absolutely.
I know breastfeeding can also have a big impact on, again, those hormonal issues. And so you may not have as much natural lubrication or desire, or again, sex may be more painful. Even, I know a lot of women are really kind of surprised because they've always enjoyed sex prior to pregnancy or breastfeeding. And so it can be a real shock, or even kind of, you almost have to go through some grief work that
You bet.
feel like you lost a piece of yourself as you have this beautiful baby, and that those are complicated feelings.
You bet.
So yeah, those are all really, really great things to be thinking about.
I agree.
Well, good. We're right about an hour of maybe even a little bit over. So again, these are things that we could definitely do further podcasts on, get more specific on certain areas on. But I think this has been a really good overview of some of the issues that come up both physiologically and psychologically as people try to handle these types of really kind of sometimes painful and confusing situations. But I'd really like to give you an opportunity to either share anything that I haven't asked you about, if I haven't covered everything that you were hoping to cover today, and even just get some of your closing thoughts.
Sure. I think just in closing, the only thing left on my mind is just a reminder that sex is more than intercourse. I know that a lot of my clients, if not every single one, to a certain degree, I have to, we end up going over the spectrum of sexual experiences and intimate experiences, and what they all mean to the person and their spouse or the couple. And so many people in our culture get caught up in all or nothing thinking when it comes to sexuality, and what they're really thinking is that it's either intercourse or nothing. And I think there are just so many contributing factors to this. But a big one for women is not feeling empowered enough to show up to the sexual experience and saying, I don't really want to go here, but I think this sounds very fun to share with you tonight, whether it's, something in between intercourse and cuddling on the couch. And so there are just countless experiences that spouses can experience together. And just because intercourse is compromised right now, or your genital play, whatever might be going on, there are so many other ways to be close, while these other things might be being treated or looked at from the team that you're getting into. So yeah, I think that's just another really important piece that I think is good to close on. Just that intercourse is important. It's a great part of being in a relationship, but it is not the only part that can contribute to a close and fulfilling relationship.
Yeah, I love that. I think that's so important. There's no one type of sex that makes a sex encounter great, so there's all different types of sexuality that we can enjoy, and pleasure, just enjoying the pleasure of touch, the pleasure of closeness. So absolutely. I love that you close with that. I can't thank you enough for your time, Kristin, and I know you're doing great work out there in Utah, and really enjoy my colleague relationship with you. So thank you so much for coming on and spending some time and your expertise helping so many people out.
Oh, thank you so much. This was really fun, Natasha.
We took the long road home, turned minutes into miles, and as the evening traveled on, the sunset bathed your smile. We stopped beneath the desert stars, wrapped in each other's arms. Was as simple as I love you, an ordinary, extraordinary truth. storm we traveled on like lovers do. And if sometimes we fell apart, we always came back home. Was as simple as I love you, an ordinary, extraordinary truth. Some people say love is blind and forever is too long. But I see your eyes in every sunrise. Can't imagine life alone. Let's take the long road on together until we're gone. Want you by my side till the day I die and into the beyond. It's as simple as our love is. That's how I wanna go, all wrapped up in the arms of our extraordinary. It's nothing